Today we're going to talk about ACL tears. A lot of people think about ACL tears in the setting of athletics. A basketball player tears their ACL, a football player tears their ACL, but this is really an injury that anybody who is doing any type of athletic activity, and no matter what age, can get ACL tears. Typically, a person will tear their ACL doing a activity where they go from a high rate of speed to not going at a high rate of speed rather quickly. A deceleration type injury, a twisting, you're going in one direction and you're planting and trying to twist into another direction. It can be as a result of contact with another athlete. You get tackled, soccer, football, for instance, that can happen as well. In skiing, if you fall, you are going at a high rate of speed and all of a sudden you're not because you fell and you twist or torque your knee in a way that can tear your ACL. Typically, patients with ACL tears will feel a pop or a sensation of painful buckling in their knee on the initial trauma which tore their ACL. Typically, shortly thereafter, you're going to get a lot of knee swelling. It's going to look a lot different than your other knee. There'll be a lot of swelling. It'll look maybe like some people will call it like looking like a grapefruit or looking like a balloon is in their knee. Typically, walking is possible but painful to do, so a lot of times patients will have to be on crutches initially. Once somebody tears their ACL, it's really important that the diagnosis gets nailed down relatively quickly. So if you do have a lot of swelling in your knee is buckling, you can't fully straighten or bend your knee, and that lasts for a period of time, then it would be a really good idea to see an orthopedic surgeon or a sports medicine physician and get that checked out. Initially, what's going to happen on exam is the doctor will look at your range of motion, so they will compare that to the other side and see if there's deficits or decreases in extension or flexion of the knee. They'll test for an effusion, and a lot of times you can do that by testing how the kneecap fits in the groove. And if the kneecap is up and there's a lot of ballottement or swelling right underneath the kneecap, that's how you can diagnose an effusion. They're going to do some specialized tests. They're going to do what's called a Lachman Test, which is basically, and you'll see this on the field with football players a lot if you watch NFL games. The trainers or the orthopedic sports medicine surgeons will come out on the field right after an injury and do a Lachman. The reason to do that is that the swelling has not started yet right after the injury, so you can get a really good physical exam right on the field, right at the time of injury, that you can't get that type of exam for several weeks following the start of the swelling from an ACL tear. A Lachman is you're moving the tibia relative to the femur like this, and if somebody has a negative Lachman test, there will be very little motion there. If somebody has torn their ACL, then there'll be a lot of give here, and you can actually feel it subluxing and moving in and out of the joint because of the torn ACL that's no longer holding the femur close to the tibia. There's other tests that you can do which are rotational, like a pivot shift test, which basically tests the ACL integrity in flexion and then twisting the knee and then extending it. The surgeon or doctor will also be testing for other things. So is there any tenderness on the inside or the outside of the knee, which can be indicative of a cartilage tear or a meniscal tear in the knee. They're going to test the other ligaments. There's the medial collateral ligament, which you test by going and putting a valgus force in the knee like this. And there is your lateral collateral ligaments, which you test by putting a varus force in the knee and testing these ligaments on the outside. There's also a posterior cruciate ligament, which is tested with a posterior drawer test, which is basically the opposite of an anterior drawer Lachman test, where you try to shift the knee like this, as opposed to with a Lachman test where you're shifting the knee like this. Your doctor will typically, if they suspect an ACL tear, perhaps get an MRI of the knee to confirm the ACL tear, and also to look for any other associated pathologies. Just because you tore your ACL does not mean you could have torn your meniscus. You maybe have other ligament injuries, and that's how an MRI can be really helpful. Typically, if somebody has an ACL tear, the first thing that I do is get them into physical therapy. They've got an effusion. Their knee motion is not optimal. You cannot do an ACL reconstruction unless the knee motion is near normal before you do it. Otherwise, you risk getting a lot of postoperative stiffness. So even in high-level athletes, when they tear their ACL, you're not hearing about them getting their ACL surgery done the next day. They are waiting weeks until the knee motion is optimized and the swelling is decreased enough that you're going to get the maximum chance of a good outcome with an ACL reconstruction. And physical therapy will be working on getting range of motion back. They'll be using modalities, ultrasound, electrical stim, trying to decrease some of the inflammation around the knee. Everybody's knee who has a suboptimal range of motion, you have to get that optimized, whether or not they have surgery. The next step is to decide, does this particular person need an ACL reconstruction? And not everybody who tears their ACL does. There are some people who are copers. They are people who learn not to put their knee into positions that cause their knee to give out. You know, they learn how to twist differently. They learn how to play sports differently, or they may choose not to play certain sports. They may feel like, okay, I tore my ACL playing soccer, but I really don't want to play soccer anymore. I really want to do cross-country skiing. I really want to do cycling. Things that don't put a lot of stress on the ACL, and maybe they do fine with that. Other people are grossly symptomatic of the ACL tear, and it's not athletics where their knee gives them problems, but it's just day-to-day life. They're walking around the office and their knee will give out on them. And those people, they're not copers, and they are not going to do well with non-operative treatment. Similarly, if somebody is an athlete that wants to get back to a sport that tore their ACL to begin with, those athletes will typically benefit greatly from having an ACL reconstruction. Basketball players, soccer players, football players, hockey players, especially sports that require a lot of twisting and change of direction. Now, once you have the decision of whether or not to have surgery, if you choose to have that, the surgeon may choose several different grafts in order to take something and put it into the knee to reconstruct the ACL. The surgery for an ACL reconstruction is typically not a repair. You're not taking the ACL and just sewing it back. Typically, you're reconstructing that ACL. You're using a tendon graft to take the place of the ACL ligament that has been torn. In the United States, the typical graft options are using your patellar tendon, which is this tendon right here, and you're going to take the central third. So you're going to take a little bit of bone here, you take the middle part of this tendon and a little bit of bone down here, and then you use that and then put it up into the knee through the tibia and then out. So the ACL reconstruction will go like that, and that mimics how a native ACL runs through the knee. Another option is to take 2 out of the 3 hamstring tendons. They're in the back. They can be taken through an incision in the front, and they can be harvested, and then that can be used as your ACL graft. Also, you can use your quadriceps tendon. That is this tendon at the top. You take this part of the tendon, and sometimes you take a little bit of a bone right here and use that to reconstruct the ACL. Or you can use allograft, which is donated tissue from a cadaver, and then you can use that tendon to reconstruct the ACL. All of them have different benefits and downsides. The patellar tendon is a very strong graft. It's the way we first started to do modern ACL reconstructions. So it's got a very long track record. They work great. The problem with them is that it does increase your chances of having kneeling pain and anterior knee pain. You can take the hamstring tendons. The benefit of that is you don't have the problems with the incision and the possible pain with kneeling and possible kneecap pain with taking the patellar tendon graft. Problems with taking the hamstring graft is that even after a year, there may be some testable difference between strength and hamstring flexion on the side that was operated on and the side that was not. Quadriceps tendon has similar types of problems with the patellar tendon, although maybe a little bit less because you're not taking as much bone off the tibial side. People tend to tolerate the quadriceps graft maybe a little bit better. The final option is allograft. The upside of using an allograft is there's no downside of taking something away from the knee and then using that to reconstruct the ACL. You're just adding the graft to the knee. Downside is there is a risk of infection. It's a very, very low risk, but it is not zero. So that would be the downside risk of using allograft. During surgery, the surgeon will do a tunnel in the tibia and a tunnel in the femur and then pass the graft. There are different ways of doing that. There are ways of going outside in, there's ways of going inside out, there's ways of going through part of your portal and then making part of your tunnel that way. The main thing about how it's done is that the ACL graft has to be positioned in perfect position, or as good as can possibly be and as anatomic as possible. That will ensure that the function of the ACL that is reconstructed is as normal as possible. After surgery, typically it's a lot of physical therapy. You're going to start getting some knee stiffness. You're going to have to start working that out slowly. Initially, you might be on pain medications, but normally not for too long. Sometimes your surgeon may use an ice machine or a compression ice machine to pump super cold water around the knee, which helps with postoperative pain. Typical return to jogging is about 2 months. Typical return to running is 4 months. Typical return to cutting activities, stopping, planting, twisting is 6 months. And release to full sports can be anywhere from 6 to 8 months. Thank you for your time.